Good evening, ladies and gentlemen. Again, thank you for being with us. Today I'm reporting to you that we've diagnosed an additional 597 cases of COVID in the laboratories in Ireland, and there have been an additional 112 notified to us from the German laboratory we've been talking about in the last number of days, and that brings the total number of COVID-19 cases diagnosed, irrespective of where diagnosed, to now 13,980. It's 13980. I'm also reporting that there have been an additional 44 deaths notified to us in the last 24 hours, bringing the total notified thus far to 530. And of this 44, 33 are in the east of the country, 3 in the northwest, 3 from the south, and 5 from the west. 25 of the 44 were male and 19 female, and the median age of these additional 44 is 84. And we've been told that there, in respect of 25 of these, there is an underlying medical condition. And we would like to take this opportunity, as ever, to express our condolences to the families and to the friends of each one of these individuals. As I've said, this brings the total number of deaths to 530. 316 of those have occurred in a hospital setting, that's 60%. 45 of them occurred in an intensive care unit, that's 9%. The median age of all of these deaths is 83. The mean age is 69, and the age range is 25 to 105. The male-female breakdown is 308 were male, 222 female, that's 58 to 42% respectively. And we've been notified that in 81% of cases, that's 430, there was an underlying medical condition. In terms of intensive care admissions, we've seen now 296 admissions to intensive care, 153 of which remain in intensive care, that's 52%. Again, a slight drop from the number I gave you yesterday. There have now been 98 people discharged from intensive care units, that's 33% of that 296. And as I've said, there have been 45 deaths in intensive care units, and that's 15% of all intensive care unit admissions. The median age of those intensive care admissions overall is 60, and we've been notified that in 243, or 82%, there has been an underlying medical condition. In terms of the detailed breakdown of cases notified up to and including midnight on Wednesday, the night before last, the total number at that point was 13,012, that's 13012. Just over 2,000 of them, 2,082 to be precise, were hospitalised at some point, that's 16%. 294 were admitted to an intensive care unit at some point, that's 2.3%. 521 of those, or 4%, died. 436 clusters notified, accounting for 2,723 cases out of that 13,012. The proportion of healthcare workers is 26%. The median age of all of those incident cases is 48, and the male-female breakdown is 44% males, 55% females. In respect of clusters, we've now been notified of 261 clusters in residential care settings, accounting for 1,628 of the cases notified thus far, and 166 clusters in respect of nursing homes, accounting for just over 1,008 to be precise, of the cases notified so far. So I'm just going to hand over to Kathleen McClellan to briefly outline some of our thinking today in relation to nursing homes arising from our meeting of the National Public Health Emergency Team. Microphone.
Settings, actions that will help expand the current information set that we have around these long-term residential care settings. And by those I'm talking about mental health, older people and our specialist disability services, and including our nursing homes. The first is that we are going to conduct over this weekend a survey of mortality within long-term residential care settings. This survey, which will be a census of mortality or of deaths from January until April, whether those deaths are COVID-positive deaths or whether they are deaths related to other issues, and whether they have occurred within hospital or within the long-term residential centre. We have much of this information, but we consider that it will be very useful over the weekend to enhance the information that we have, and it will help inform our actions over the next few weeks, and it will inform our meeting on Tuesday at NEFIT. Our second action is to increase the testing of staff at long-term residential care settings. So it's proposed that very quickly we test as many staff over a short period, commencing with nursing homes. This is an action of scale, and for example, there are over 30,000 staff work within our nursing homes. Our third action is in relation to HICWA. So HICWA will be publishing and assessing a COVID-19 quality assurance regulatory framework. This framework will extend over the preparedness of the nursing home sector, of the long-term residential care sector, and also look at areas like the actions that we have previously put in place, whether that's the active screening, temperature checking and so on. It will provide an additional assurance both to the nursing homes and to the public. And our fourth action is the urgent implementation of the previously recommended actions. We're confident these are the right actions under the right framework, and they are all being implemented. So we want to continue to see their implementation, and we want to continue to see their implementation all across the country. And in addition, we're going to introduce an actions tracker so we can assess where we're at with all of those actions. So we consider today from the NEFIT meeting, with these additional actions, we will have further information to inform our public health directions, with the key aim and goal of interrupting the transmission of this disease within our long-term residential care settings. Thank you, Tony.
Thank you, Kathleen. Now we're ready to take any questions you may have.
Zara King, Virgin Media News. Good evening.
Good evening.
I suppose it's just in relation to keeping in mind people at home this evening who might have a mum or a dad in a nursing home who are really worried about them. And maybe they're in a nursing home that doesn't have an outbreak necessarily, but they're thinking long-term contingency plans. Perhaps they're thinking, could we bring mum or dad home? Would it be safe to do that? What would you say to people who are trying to make those kinds of decisions at the moment? What advice would you give them?
So what we can say is that we're not recommending, obviously, that people take people home from nursing homes at this moment in time. In general terms, the recommendations to the public, if you like, around moving around and visiting would be against that kind of practice. I think we can reassure people that although we've seen a significant impact, and we continue to do, and we're continuing to be concerned about it, for people who are both vulnerable in the population and in particular people who are living in community residential, in some of our community residential settings. The work that we're doing and the work that is being done by the HSE is focused on trying to provide as much protection from the transmission of this infection as we possibly can, and then to enhance and step up, if you like, the quality of clinical care that's provided to people. So I think we can reassure people on that basis that everything has been done to try to ensure and assure ourselves that as much quality care is being provided to those individuals. And we are now working with the Health Information and Quality Authority, the regulator in this sector that has a relationship with each one of these registered centres around the country, to give us, if you like, independent reporting, to give us exactly that assurance that the right measures and the measures that are specific to protecting people who live in these settings in as much as we possibly can from this disease are being taken. Colm Henry might want to add.
Yes, just to add to that, the best place for them is to stay there. It's the safest place. Most nursing home facilities, and they're much more modern facilities nowadays, have effective isolation rooms. And if you recall the advice given on cocooning to all over 70s, irrespective of where they are, the most effective place for that to happen is in a nursing home setting, in their own room. Once people are brought out of there, not only will they not receive the same care for which they entered the nursing home in the first place, but secondly, they're exposed to risk of transmission in the community, which is a very real risk. So our nursing homes are exactly what they say. It's a home where nursing care is provided. People enter there for a reason based on need, and they enter there because their care needs can no longer be managed at home in what was previously their home, but in this nursing home. So stay put. There's a heightened sense of awareness in terms of infection prevention and control measures in nursing homes. There's increased supports, and also there's a heightened awareness of the atypical presentation we talked about earlier today and yesterday that can occur in older people. So the effective diagnosis and effective intervention will be made at an earlier stage by the medical care and nursing care in the nursing home setting.
Kathleen might want to add something to that. Yeah?
I just might add, if people are worried and they are concerned at home, I think the first thing they should do is, because they will already have good relationships with nursing homes, because these are the homes for their mums and for their dads and for their relatives. They should ring up those nursing homes, have a conversation with them, reassure themselves, and try and have whatever contacts and conversations they can have with their family members as well. I think that's the first thing that they should do, and I think that will be very helpful to them in reassuring them how their mum or how their dad is within that nursing home.
Yeah, that's great.
Hi, Shane Beattie from News Talk. Tony, just one of the recommendations from NEFA today is that, or a decision is that testing will be expanded to 100,000 tests a week, 7 days a week, every week for 6 months. Is that correct? And when does that kick in?
So we want it to kick in as soon as possible. We want to, I think I outlined to you previously, some of this is based now on our hope that the disease continues to follow the pattern that it's following at the moment, that the rate of growth drops, and that we're not, if you like, concerned about the disease as we approach the 5th of May. So on the assumption that the disease is, as I've put it before, behaving itself in the way that we want, we would seek probably to change our case definition to make it more sensitive towards the end of next week, and for that to become operational the week after that, on the beginning of the week, and so that our general practitioners in particular will have time to prepare for that, and it will be the general practitioners who will be in the front line, if you like, applying that case definition. We'll want to have that capacity in place for that point in time. We know already that the HSE has gone a substantial way towards giving us that level of capacity already. While it might not be quite at that level, it's a substantial way down that road through the work that's been done, particularly in the last couple of weeks, to try to step up that testing capacity. And there is now, in effect, spare capacity within the testing capacity that the HSE has available to it. We want to see that spare capacity used in the next week to 10 days to facilitate much greater testing of both staff and patients, according to the arrangements that have been put in place by the HPSC to plan those testing studies in the next week or 10 days to use that capacity wisely. But that's the kind of time frame, Shane. Yeah.
And when people hear, because people have the experience of waiting up to 2 weeks, some longer, some shorter time for their test results, when they hear that we'll be doing 100,000 tests a week, 7 days a week, that's what, 14,000 a day or whatever, what people will hear is backlog, backlog, backlog. Are we going to have a backlog with 100,000 tests a week?
The entire intention of this is to put us in a situation which is not the experience that we've had heretofore, that we can turn this around within a very short period of time. I've said to you before that our intention is to have the sampling and testing and results back to patients on a real-time basis. If we move into a situation where we're lifting restrictions because we're satisfied that the disease in terms of its spread in the community is at a very low level, we have to be in a position to catch that if there is to be an increase in cases occurring in the community as quickly as possible. We cannot have anything other than real-time turnaround in terms of those test results. So we cannot be dealing with some of the kinds of delays that we've had heretofore. And you'll see, and I've referenced this already, the WHO has produced even tighter restrictions, or tighter, I should say, advice in relation to those turnaround times, and talks about a period of 24 hours in its most recent advice, which was published at the beginning of this week.
Okay, Dr. Henry, Colm Henry, if I could ask you, a couple of hours ago we were told by the HSE that we would be prioritising testing for residents and staff in nursing homes where there had been an outbreak or a suspected outbreak. What's changed in the last couple of hours that now it's all long-term residential care facilities?
We're prioritising. Clearly, there's a high number of outbreaks in residential care facilities. We've been working with Lorraine Doherty, who's head of the new head of National Director of the HPSC, and with an effort. Our intention is to aggressively test and pursue all suspected and cases in nursing home settings and staff. So there's not much difference from what happened a few hours ago. We're just expanding and progressing. This is the biggest at-risk setting for us at the moment. As has been described earlier in the week, it's some relief to us that we didn't have to lean into the surge capacity in our hospitals, but clearly our priority now is to tackle these outbreaks in nursing homes and the particularly hazardous environment and the danger that presents to residents and to staff.
Okay, and just final question from me for Dr. Tony Holland. How does it sit with you, the idea of a company chartering a flight and bringing 190 people from a different country here to work? I'm sure you'll be aware of what's going on with Keelings. A lot of people are talking about it on social media. obviously, you know, our borders and airports remain open, albeit much reduced capacity. But are you comfortable with the idea that companies are chartering flights going to countries and bringing 190, 200 people to this country?
No.
So what's your response to Keelings and what they've done then?
Well, I didn't know about it. Perhaps like you, became aware of it after it had happened.
And what would you say to companies like that?
So it wouldn't really be consistent with the public health advice that we've been giving. And I think some of that advice does have implications in relation to travel and for people who are travelling, and we've been very clear and consistent in what that advice is. I don't want to be critical of any individual or any individual circumstance. I don't know the details of the circumstances. I'm aware of, in general terms, what's been reported in the media. But I think what I would refer you to is our consistent public health advice. We've continued to keep the issue of travel on our agenda, and we will as we come through the next 2 weeks, moving towards the 5th of May, to try to address what arrangements we might need to have in place at ports, in both airports and seaports, and points of entry onto the island from overseas, in a situation where we might be thinking about lifting restrictions. And we're also bearing in mind that there are other countries across Europe and elsewhere that are probably ahead of us in terms of lifting restrictions and might be increasing the number of people who are, if you like, in a position to travel. So we think we need to give ongoing consideration to that.
Okay, thank you.
Okay, Shane.
Ronan Duffy from the Journal.ie. Just to follow up on that, I think the Department of Agriculture responded to that in the last while, saying that seasonal workers are important to maintain supply chains and so forth. And I think we have seen in places like the UK and Germany, people have come abroad to ensure that those supply chains are continued. But what can we do, or can NEFRA do anything to ensure that businesses do comply with the advice that's given? Is there anything more we can do to ensure that that happens?
So we continue to give advice, and we'll give advice to whoever wishes to have advice from us. We've provided advice to a variety of different sectors. We provide advice on a cross-government basis. We work with other government departments in relation to the advice that might need to be provided to their sectors, and we'll continue to do that.
And you referred there to a number of countries who have, started to reduce some of their restrictions or loosen them. Has the department, has NEFRA had any learnings from what's happened there, and has that been shared as part of that meeting today?
Good question. Probably a bit early yet. The countries were, and we were obviously interested in any country in terms of a change in restrictions that might have applied across the world. We're particularly interested in those in Europe, and we're keeping a close eye on those. They've just made some of those changes in recent days. Probably a little too soon to see the impact of that in terms of disease and disease control. It's likely that you'd need a period of maybe 2 to 3 weeks to be certain in relation to what you might be observing in disease terms as a result of a change in the impact of an individual measure. But we'll keep all of those things under review, and if anything changes as a result of what we're observing internationally, we'll be on it, if you like, and reflecting it into our ongoing considerations.
Okay, and just a question for Colin. I think you have talked about the lack of gowns. I think with the availability of gowns was an issue you raised at the weekend. I think I've seen in the last hour or two that NHS staff have been told to work without gowns to treat coronavirus patients without them. Are we at that point yet, or how close to it are we? And, on that issue of gowns, where are we?
Yeah, we were in a very perilous state at the weekend, not because we'd run out, but because the supply lines coming in weren't meeting the daily demands. And I'm happy to say that's been addressed now this week with the arrival of multiple plane loads, which were very heavy on those long sleeve gowns and the coveralls we need. That said, it's important, and we're reminding all our staff that all those elements of PPE are hard fought for and hard secured, and we want to protect them in the right place, so the right staff use those PPEs to protect themselves and protect patients and to prevent dissemination of the virus. So we're more secure now in the supply lines we're getting through. We have some concerns over a certain type of respiratory mask, but there's endogenous production has trebled from a factory in Kilmallock and Limerick, producing 150,000 per day, per week. Sorry. So we have those Chinese stocks coming through, which are coming through in enormous batches of 30 million items per batch and more, and we also have production ramping up within factories in Ireland. So but demand is unprecedented because of the impact of this virus, not just in hospitals but in community settings.
we're not at a point where you might have to advise and reusing or anything like that?
Fortunately, no. But to remind people, before we secured these supply lines, we were in a situation where we'd run out of certain elements of PPE, such as goggles. We're now in a happier situation. We've secured supply lines, but as I said, the demand is unprecedented. And when you look, for example, at community settings with frail elderly individuals who may require turning regularly as part of their skin protection, that requires PPEs for staff in that exercise a number of times per day. So demand, which was normally in very well-defined clinical settings before, usually in hospital settings, has now expanded way beyond that. And so the supply we have is enormous, and the batches we have coming through are huge. But it's hard work for us to continue to meet that demand, and we're as I said, ramping up internal production and securing alternative supply lines in addition to the one secured with the intervention of the Chinese ambassador, to whom we're very grateful, I must repeat.
Thank you. George?
Just, I suppose, before you get off that point, Colin, could I ask you, as George Lee, there was the batch of reagent from China which had been ordered that the HSE had very clearly said they were taking a risk with. It would have had to be checked and verified that it would work. Do you have any update in relation to that, whether or not the testing of that is finished, or can we rely on that?
We can rely on it, George, in short. I won't go into detail, but risk might be a heavy term. It was that it hadn't been 100% reconciled with our own lab system, but I'm happy to say that has happened.
But you're happy enough that reagent is approved for use in our lab?
It's a reagent and test kit, so it's a test system which is now in operation, yes.
Okay. Can I just ask, Tony, about this testing blitz, which is very eye-catching, over the next 7 to 10 days? The staff and residents in all long-term residential care facilities will be prioritised. I think, Kathleen, didn't you say 30,000 staff work in nursing homes, and there's 28,000 residents in nursing homes? That's quite a blitz, really, isn't it, in terms of, are you happy that we'll be able to do that in 7 to 10 days?
I think we'll do our very best, and I think the HSE has already started today. I think nursing homes and residential settings in the east of the country have already been visited by the National Ambulance Service, have already begun to collect swabs, and they'll be into the laboratories over the course of the weekend, is the information that I have.
And is it a case that it will focus on nursing homes which have COVID patients first, or residents first, and then move on to the other nursing homes?
So there may be a question of order and priority in it, of course, and the detailed work around all the planning of that is happening, as Dr. Henry has said, through Lorraine Doherty, who's now the head of the public health function in the HSE and head of the HPSC. So there will be a focus in relation to those centres that have had experience with this infection. There will be a focus also on staff in particular in places that have not yet reported cases of this infection, and then perhaps also patients in those settings, guided by ultimately the findings as they go along through the next 7 to 10 days. Yeah.
Okay. I wondered, Kathleen, have you any idea, because obviously with nursing homes, we know there's about 28,000 patients and 30,000 staff, as you told us. In the other residential care settings, do we know how many people we're talking about between staff and residents? I'm wondering.
We're probably, and I don't have the exact figures here because we're actually just getting the exact figures from the HSE in terms of the disability and the mental health organisations. But what I can tell you is that we have about 2,600 beds across our mental health facilities, so that should give us an indication of the numbers. And we have about 8,300 residential places in disability. So it's quite a significant number that there will be across the disability and the mental health services. So we're working with the Mental Health Commission as we speak here this evening to ascertain the staff numbers there and the total numbers within beds. And the HSE is providing us the same in relation to the disability services.
I'm sorry, it might have been my scribble. Did you say 2,600 beds in mental health or 2,000?
2,600.
600, okay.
Yeah, 2,000. Yeah, yeah.
And one other question, Tony, in relation to these very substantial measures that you've announced today. The census of mortality across the long-term residential care settings. It is possible that you will find that there have been more COVID-related deaths in that census. It is quite possible. And I'm just wondering in relation to if that happens, How will you handle that data? Will you and I say that on the basis of the discussion we have had about the German tests and the confusion probably that was caused, but it might be better to clear that before we ever get to a confusion. If you do find that there are a backlog of cases that weren't noted before, how would you like, or how do you intend to deal with that in terms of the ongoing numbers?
So we'll do it as we've always done with these. So we get them notified on a day-by-day basis, and we'll report that number on a day-by-day basis. If we do identify any additional notified deaths, so the survey will identify what the number of deaths has been, but that will be a total figure. It won't necessarily be all of COVID. So we just want to try and understand what the pattern of mortality is. Bear in mind, George, that people in this country have a period of up to 3 months to notify deaths. So not all deaths are notified until the end of that 3 months, at least. Even if the majority of them will be notified within a short period within that 3 months. So this gives us a window in which we can understand what the full picture has been. It doesn't necessarily mean that there's been an increase in the number of, but it'll give us a better understanding of what the overall mortality has been. We want to then improve our understanding of COVID and the role that it might have played, and that's part of the reason that we would have communicated, as I told you yesterday. I wrote to funeral directors, asking them to work with us, to work with families, to encourage them to notify earlier. There's now a means through which people can online notify deaths to the GRO, and to make that process much faster than it normally would be, so we can have a more real-time understanding of the overall pattern of mortality in the population. And we'd also like to see, so we're writing to medical practitioners to have them notify, to consider this particular diagnosis, and to have them do more testing in these situations, because we'd like to understand that more. And we think we might identify some additional cases of COVID-related deaths, which isn't to say that we necessarily think that there's something large that we think we might have missed. It's simply to say that we're doing everything we can to try to understand the pattern of mortality that might have unfortunately arisen in relation to this particular infection in the places that we're targeting and identifying, which unfortunately are the places where we have seen significant mortality already. I think we're doing that in ways in which many other countries have not yet done or prioritised. We will find, we may find additional deaths that we haven't yet had notified to us, but that's the purpose. We want to try and find as much information as possible and to know as complete and as real-time a picture of what's going on in these settings as possible. We think we have a good understanding. We've given you the notified number every single day. One of the things to kind of bear in mind is that although we give you a number, and I've given you the number today of 44, it's not to, so that's 44 notifications received today. It's not to say 44 people died in the previous 24 hours.
Okay.
And we have a distribution. I could show you that, I think, if you want. That'll give you an understanding of that. So that's actually when you take the notifications and you plot them according to the date that death occurred, and you can see that the very peak of that was on the 7th. I don't want you to interpret that as meaning that that the mortality has fallen, because there's always a lag time in terms of reporting. But that's simply if you take all of the deaths that have been notified to us so far and you plot them simply according to the date on which the death occurred, you'll see that the largest number, in fact, on any individual day was, I think that's 39, and it was on the 7th, which is 10 days ago.
But that is a significant difference in terms of the kind of numbers that we would have been looking at.
So the notifications have been increasing, and I don't want to either overplay or overinterpret what that means, but we want notifications we want to be told about more deaths that people are suspicious about, and we think that people are telling us more of that, which is good. We think we're getting better reporting, which is good. And the numbers we give you are the numbers we're notified of every day, and then the work that we do is to plot those. And so the numbers that we would have given you comprehensively yesterday evening from Philip Nolan, where he would have said that we're starting to see a levelling off in terms of the numbers, he's been plotting all of these. So any death that we have that's COVID related, we will plot that according to the date in which the death occurred.
So if somebody wants to understand the trend, and I understand your caveat that you have said beforehand, but it's that kind of stuff you're looking at. When did they occur? Have we changed? Rather than the actual headline increase on a day.
On a day, yes.
On a day
because
because
if I remember rightly, and I did look at this earlier on, if you look at the 44 deaths that we were notified today, the largest number on a single day in relation to those 44, in fact, was 6. So they were deaths that occurred over a period of time that were notified to us today. But when you plot them according to so that's the full 500 and, what's the precise total now? Full 530, each allocated to the day on which the death occurred, and that's what it looks like. But don't conclude from that the drop-off at the end is a real drop-off in terms of that could be just a delay in the notification of those deaths.
We just have to wait. Is that over a period of time?
We have to wait, George, to understand this and to understand, and Philip would have said that as well clearly yesterday evening. It is always the case that in terms of the experience of this illness, the nature of the deaths is it occurs a period of time after the incident case. So there's always a lag between the incident numbers, if you like, and the admissions to hospital and then mortality.
It is a very interesting difference in terms of a trend to the one that we have been looking at. It actually is quite striking in its difference. But I accept that you have to wait because clearly there are lags, so you don't know what that means. But it is well worth watching.
So, yes, it is. So we are seeing that fall off, but I think we need to wait before we can conclude what that means in terms of any long-term conclusions that we can make in terms of mortality.
Wow. Well, could I ask one other question
Sure.
Related to the nursing homes? And this is all this blitz of testing. It's my word, blitz. Okay, so I'll think of it like that. It's a lot of testing in a short period of time. In that, obviously, as you test, you are likely to find more people who are COVID positive. Have the nursing homes got the capacity to deal with all of that? Like over a period of 7 to 10 days, they could find out a lot of patients need to be isolated. Do they have the room, or what would happen? Will they be able to deal with that pressure in such a short period of time, I'm wondering?
Challenge for some of the older places, for sure, but based on what I saw yesterday, I'm citing that because of the most immediate memory, where Abby Collins, who's the public health lead in the Midlands, Port Leash, she dealt with a range of nursing homes, including where the outbreak was in St Fintan's, a very old institution, and she was able to give advice appropriate to each institution. Many of them have isolation beds. Otherwise, she looked at cohorting, and the cohorting isn't exactly binary. It's not just a question of cohorting positive and negative patients. It's looking at patients who've ever had contact or had no contact whatsoever with the patients. So she was able to work with the medical and nursing staff in St Fintan's in enabling effective cohorting, as happened at St Mary's Park with the work between the public health and the two consultant geriatricians who are serving those areas. So each place has different challenges. The more modern places clearly have single room occupancy and present a much easier scenario in terms of isolating people effectively. So it is up to each institution and the public health advice, George.
Very challenging for some of them, though. Yeah, Kathleen?
If helpful, I can add, the Minister and a team here, we met with Nursing Homes Ireland today. So we outlined for them our plan over the next week and the issues. So undoubtedly it will be challenging, but we're giving people time to start to plan. And the HSE was present on that call as well, because we are trying to build the resources, including the COVID response team, so that they can support nursing homes there. It is the right thing to do, but that doesn't mean that it isn't going to be challenging, but we're going to plan in as much as we can around that.
Okay, so you will work with them and help them out as much as possible, but it's difficult. But there's no right answer till we see what the story is. And one final issue in relation to, obviously all of this change in the testing regime is quite striking and will be striking to many people to hear 100,000 tests per week ongoing 7 days a week for a minimum of 6 months. The reality is we're still hearing of people who are waiting. Some of them still tell us they've been waiting 4 weeks and have had no result on a test. And they wonder, are they to forget about their test? Is it lost? Or what would have happened to those test results that haven't come back? And I've no doubt that there will be people who hear all this ramping up of testing and are wondering, I never got my result. How can they be doing this? Am I forgotten about?
I think there are two parts to the answer to that question. So one is about the significance of and can they forget about the tests, is the way you put the question, and the other about what
people are probably wondering that.
Yes, exactly. We think it's much more likely that tests were not reported are negative, but there are measures been taken to try to provide even negative reports back to individuals even at this stage. That's the first point. The second point is that if a person followed the advice that we gave all the way along, and it was the consistent advice that it was the public health action that people took that was important and not the test. And the public health action was if you had the symptoms consistent with COVID that caused, if you had a test, your GP or somebody else to recommend that you have the test, and you had the test and you haven't got the result, to assume that you have COVID-19, to self-isolate for 14 days, to restrict the movements of your household contacts, and that was the key measure that would stop the transmission of this virus. And that if during that 14 days, obviously if somebody became unwell, they would have been advised to attend their GP, and that would be but if somebody remained well and recovered, and in particular concluded that 14-day period, and at the end of the 14 days, the final 5 of which was without a fever, they can regard the infection as being cleared and for them to be safe to go back into the population. So I think the majority of people will be in that category who have not heard a test result, and they can regard it as something, I wouldn't say that they can forget about, but that it doesn't have ongoing significance for them, that they're not at ongoing risk if they've completed that particular time period and that they remain well.
Still might feel a little bit let down that they never got the result.
Yeah, because it wasn't the intention of the healthcare system to not feed back to them, absolutely. And we'd understand that that was the case. But I believe that measures are now taking place in the HSE to ensure that people who, even at this late stage, can have the, if I can put it this way, have the loop closed and that we can move on. But that will not be the experience of testing. Now, the whole intention is to put in place a rapid turnaround system, because that's what we need for now, for the nursing homes as we move on to in the next week, and it's certainly what we're going to need as we move through the period from the 5th of May for the reasons that I've outlined earlier on.
Okay. You prompted, now I was about to sit down, but you prompted one question, which was only in the back of my mind, Tony.
That's right, George.
And it was the fact that there are so many asymptomatic people, and we know more and more evidence of this globally and so on. And in relation to the symptoms, then people wonder, well, they don't have the symptoms, they're asymptomatic. But it appears, at least I've certainly come across it in many places, that there are symptoms which relate to the loss of taste and the loss of sense of smell. And that in up to 30% of people that can be a symptom. And I'm just wondering what your view is of that. Have you come across it? It may well be an indicator of people who are asymptomatic, who don't have the other symptoms. They may have lost a sense of taste and smell. And it has been said elsewhere and in other literature that this is an indicator.
I think Dr. Henning might want to come in on this, but if you look at the ECDC risk assessments, you'll see quite a long list of what's quite a varied set of symptoms and a percentage prevalence associated with each one of those symptoms in relation to this particular disease. The ones we've identified are the ones that are most common. Yes. But there's a myriad of, let's say, less common and less usual symptoms that have been reported in association with this disease. And it can present atypically, obviously, in people who are older. But Colin?
Just briefly, absolutely, I agree with that. These are, if you like, retrospectively useful in the sense that it's something you can look back on.
Okay.
But at the time when you're trying to discern whether or not somebody is a suspect case, it doesn't have as much sensitivity or specificity. So those cardinal features of fever and a new onset cough are the principal features which point towards a diagnosis of COVID-19, particularly in the setting of an epidemic.
Okay.
And thank you. If I can just point out on that, so they're the most common symptoms, the one that we use in our case definition, and it's still the case that the great majority of people who are tested on suspicion that they have those symptoms, in fact, don't have COVID-19, because maybe about up to 20% of samples are positive, which means 80% of them are not.
Okay. Thank you very much.
Thanks, George.
Sarah Pollock from the Irish Times. I just want to come back to the issue of foreign workers coming into the country. There have been calls from a few people today for more clarity around how quarantine will work in the 14 days. So is the onus on the employers to ensure that quarantine will happen? Who's going to oversee that these people who are arriving in are definitely staying away from the communities around them?
So just a couple of points on that. So obviously ports and airports are open in this country because we have people who are citizens of this country seeking to return, and the recommendation in terms of quarantine, in terms of self-isolation for 14 days absolutely applies to them. We have people who are involved in continuing the supply lines of essential requirements that we have to function as a society, whether that's food, whether it's medicines or other things. And from time to time we may well have people who, by reason of their expertise, and expertise we might not have in this country, we might need it at a point in time. I'll give a simple example. If the MRI scanner was to break down in the Mater Hospital that needed to be repaired, we might need to have somebody from outside of the country who's not a resident ordinarily enabled to come here, so that would be essential. We don't want to see any other form of travel coming through the ports and the airports other than those kinds of categories, and that's been our clear recommendation. And anybody who's coming through the airport in the categories that we've identified, we see the public health advice that we've given as applying to those individuals. What we're also then doing, which I was suggesting in the earlier answer, is looking at what additional or supplementary things might need to be contemplated as we move into a situation where we have, as we believe we have, suppressed the infection to a very low level, what we can do about the potential sources of further infection, which could be, if there was to be an increase in travel into the country, particularly discretionary travel, we want to see no non-essential travel into the country, or through some means like that we can pick that up as quickly as possible. But the first thing has got to be to ensure that we don't have a continuing source of that, and we're giving ongoing attention to what it is we might be able to do to give ourselves the greatest assurance that, albeit that the footfall, so to speak, onto the island from overseas has reduced by way over 90%, and that we still have as much assurance as we can that we reduce the likelihood of importation of this. It would only take a relatively small number of people who dispersed around the country to provide, as we call it, the seeding for the growth of an infection. If they were mixed among us in the community, that could lead to a significant amount of infection within a relatively short period of time. So we have to be very cautious and careful about that.
And are we confident that the translations are there for people who perhaps might not speak English, who are coming to do the kind of work that we saw with Keelings, that they will understand what the measures that we have put in place?
So I think there's a variety of different translations. I couldn't give you right now a comprehensive account of exactly what languages, but I know that there is translation of the public health messages into a number of languages. Over 20 languages. Whether that covers any particular group or not, I don't know in respect of an individual company. But we've made every effort to try to ensure, and we'll be looking at trying to see, can we step up arrangements and information and so on at ports as we move to and through the 5th of May. Those are all things on our agenda at the moment at the NEFIT.
Thank you.
Thanks, sir.
Sorry, I just wanted to ask back on nursing homes. We learned overnight of another very high death toll in a single nursing home. We see a ramping up of measures today. I'm just wondering, is that directly related to those kind of numbers you saw this week in those kind of nursing homes where the death toll was so high? Did they shock you?
I wouldn't use those kinds of words. That the pattern of mortality that we see, the pattern of infection that we see in the nursing homes in this country has been broadly similar to what we've seen, and we've seen more significant levels of mortality in other countries. These are the kinds of populations that we know, unfortunately, are vulnerable to both the spread of this infection because of the nature of the environments in which they live, and also to the impact of the infection because of the severity of the illness in people who are older and in people with underlying conditions, and many people in these settings fall into, if you like, both of those categories. So in that sense, it's not a surprise. That doesn't mean that it's not a concern. It is an ongoing concern. It's the reason why at the NEFIT for a number of weeks now we've been particularly focused as we moved into a situation where we felt we had the right set of measures in place to interrupt the chains of transmission in the community, which we now see that we have managed to do and to achieve for the whole population. And we needed to do that to protect the most vulnerable. If we didn't prevent the spread of infection in the population in general, we couldn't protect anybody in the vulnerable groups. We then focus on the institutional settings and the places where we believe the infection exists, and that's why for the last number of weeks we've been especially focused on this with the measures that Kathleen identified earlier on. We think that they are the right set of measures, and what we're seeking to do now is augment that with the role of HICWA, with the testing strategy we've talked about, and to try to identify, in as much as we can, to leave, as it were, no stone unturned in terms of trying to understand the mortality experience in these settings.
Is there any target turnaround time on that testing of the staff and the patients in the nursing home settings?
So we'll want to see that turned around on a real-time basis, and as I said before, that's same day or next day results.
That's this batch of testing that's ongoing from there?
Yeah, absolutely.
And just on the other blitz of testing, seems to be the first time we've heard about this 6 months of ongoing testing at that level of 100,000. Is that a change in strategy, or was that always going to be the case that you would,
that was always
roll
the case.
that out for that length of time?
It's not the first time it's the first time you might have heard us committing to that number.
Yeah.
But what we were clear is that we would want to identify the requirements for testing, for contact tracing, for sampling, and so on, to give ourselves the greatest chance of detecting a case if we got into a situation where we were lifting the measures. And we've done some work to try and identify what we think that right number is. So we've identified that number and formalised that advice today at the NEFIT and provided that advice to the team that's building.
That 6 month time frame is not a new.
So with the 6 month time frame, it's like to enable that planning to be put in place. It doesn't mean at this point in time that at the end of that 6 months we'll necessarily be stopping. I think at this point to predict where we'll be in 6 months' time would be a little challenging.
But nothing changed to make you go, today we're going to do this for 6 months at this particular time. It's not a change in any strategy in that sense.
Oh, no, it's not. So we were always going to be focused on building up and we've been saying that for some weeks now, building up the testing capacity to a level that we thought was going to be the right level to allow us to change the case definition, to allow us to contemplate lifting some of the measures after the 5th of May. And building that testing capacity had to have a target, and we've identified that target now for the HSE in terms of capacity, and that's a testing capacity of in and around 100,000 tests a week, and everything that implies then in terms of the quantity of sampling that will be required, the scale of contact tracing that will be required, the requirement for ongoing active surveillance of any contacts and testing of contacts and so on. And we've set all that out clearly on a number of occasions here.
Thank you.